Good morning, everyone. So my paper today is going to be on the impact of subfoveal choroidal thickness on clinical features and long-term outcomes in PCVs. I have no financial disclosures to make. So we know PCV is an exudative retinal disease which is characterized by a thick foveal, subfoveal choroid with dilated choroidal vessels, presence of a neovascular network between the RP and the Brooks membrane, and there is an hyperreflectivity between the RP and the Brooks membrane suggestive of a branching vascular network. Currently, the PCV classifications are based on number of imaging modalities, primarily on the angiography, on the basis of fluorescein, indocyanine green, and on basis of OCT angiography as well. But subfoveal choroidal thickness is another way of classifying PCVs, where on the basis of the choroidal thickness at the fovea, we can classify the PCVs with thin choroid, medium level choroid, and thick choroid. Why we use the subfoveal choroidal thickness is basically it has been used to evaluate the visual outcome in a number of retinal diseases like DME and CSCR. And when we looked at the literature, there was a similar paper which spoke about the comparison of clinical features and the 3-month follow-up in different choroidal thickness in PCV. And what they found was that these eyes with thin choroid usually had a worse visual outcome than eyes with a medium and thick choroid. But the flip of this paper was it did not have long-term follow-ups and the evaluation was done at 3-month treatment. So in this study, we wanted to look at the clinical features and the long-term clinical outcomes in patients with PCV in eyes with different subfoveal choroidal thickness. So coming to the methodology, this was a retrospective observational comparative study of patients diagnosed with ICG as PCV in treatment-naive cases between January 2011 to June 2019. And these were the patients who underwent ocular examination with visual acuity, slit lamp examination, and imaging test with color imaging, color fundus imaging, and EDI, OCT, and fluorescein and indocyanine green angiography. So the diagnostic criteria for PCV was based on the Everest 2 guidelines, where it said that you have to have an orangish nodular lesion, which is identified on the ICG as hyperfluorescence. And they should have remaining one of the minor criteria, such as the presence of a branching vascular network, a pulsatile polyp, a hypofluorescent halo, or orangish nodule, and associated with a massive submacular hemorrhage. These were the exclusion criteria. That means the cases which did not fit into the diagnosis of PCV were excluded. And on evaluation, we evaluated the patients based on the clinical examination, on the angiography, and on OCT, where on the angiography, we looked for the number and the location of the polyps, the presence of branching vascular network, presence of dilated hyperpermeable choroidal vessels, and leakage from the branching vascular network on the FFA. On the OCT, we looked at the type of the pigment epithelial detachment, presence of double layer sign, presence of hemorrhage, hard exudates of fluid, hyperreflective material, and Pachy vessels. The measurements were done by two people. And the measurements were on the central retinal thickness and the subfoveal choroidal thickness. So on the basis of the subfoveal choroidal thickness, which we got, we divided the patients into 3 groups. One with thin choroid, where the subfoveal choroidal thickness was lesser than the mean minus 1 standard deviation, and thick choroid, where the subfoveal choroidal thickness was greater than mean plus 1 standard deviation. And the values which lied between these 2 ranges were considered to be in the medium choroid group. We also looked at the treatment modalities which these patients received depending on the site and the activity of the lesion. And basically, these patients were treated either with observation, anti-VEGF injections, PDT, or a combination with focal laser. So at the final follow-up visit, we found we were looking at the best corrected visual acuity, the activity of the disease, the OCT features, and the ICG features. And we also looked at what changes were happening at the central retinal thickness and the subfoveal choroidal thickness. So we used a statistical test with the GraphPad Prism software, and these were the results which we found. So there were 12 eyes with in the thin choroid group, 46 eyes in the medium choroid group, and the thick choroid group was 10 eyes. And we did not find any difference in the demographic features or on the clinical examination features between the 3 groups. When we looked at the OCT parameters, there were a number of variables which we tried to look, and in each of these groups, that is between the thin choroid, the medium choroid, and the thick choroid, we did not find any significant change between the OCT features in this group. And similar with the ICG and the fluorescein angiographic features, so it did not show any features at the long-term visit. When you looked at the follow-ups, these follow-ups on treatment did not, the number of injections which these patients received in the thin choroid, the medium choroid, and the thick choroid group were not significant. They were not statistically significant. And the number of PDT sessions which the patients required were also not statistically significant. Now, looking at the final visit, where you found that the visual acuity did not differ between either of the three groups, that there was disease persistence or the disease recurrence rate also did not differ between the three groups. And again, the OCT, the ICT features did not show any variations. What we found on the visual acuity changes between the initial and the final visits were that there was no statistical significance difference between the presenting visual acuity or the final visual acuity in either of the three groups. So the important take-home points which we had from the study were eyes with PCV are known to have a wide range of subfoveal choroidal thickness. There is no difference in the clinical and imaging features between the three groups at the initial and final follow-up visits. The range of the subfoveal choroidal thickness was noted to be much narrower, with the thinnest being around 107 microns and the thickest being 444 microns. Eyes with PCV having a thicker choroid usually present at a younger age, and there is no significance between the OCT and the angiographic features between the three groups, and there is no difference in the functional outcome in the three groups before and after therapy. So when you look at the limitations were, this was a retrospective study. There was a variety of treatment modalities which were given, and the subfoveal choroidal thickness was not measured at the same time. And the future idea is that we need larger prospective longitudinal studies with larger sample size, which is required to evaluate the visual outcome after treatment. So eyes with PCV, they have a choroid varying thickness, and clinical and imaging and treatment responses are similar between the three groups in this study. Thank you so much.
Thank you, Ramesh, for a nice presentation. I just wanted to ask you only one question. Now, when the PDT is not available for future, though this was a retrospective analysis, for maybe another prospective analysis, do you think you will like to modify your criteria, or you like to add on something in that?
Yeah, so probably PDT, since it's not available, we will have to compare it between the different anti-VEGF groups, especially with the newer molecule coming up. Probably a comparison, head-to-head comparison between aflibercept and probably brolucizumab would be an important thing to compare, especially when the PDT is not available at such scenarios.
Yeah, or maybe it is more beneficial in thicker choroid or a thinner choroid. You know, things we need to look into it. So very nice observation. Thank you so very much.